Okay, welcome to the WPS Combined J5 and J8 Contractor Advisory Committee meeting. Today's date is February 22nd, 2024, and the time is 5 p.m. Central Time. My name is Juan Shelly Perez. I am one of the WPS CMDs and will be moderating the meeting with my co-chair, Dr. Christopher John, the Missouri Anesthesiology CAC representative. The purpose of the CAC is to present the draft LCDs up for consideration and to take comments from the CAC members. The public is the the public is welcome to attend in a listening only capacity. Let's do a sound check. Do everybody hear me well?
I'm meeting now. I need you to stop.
What?
Guys, I'm sorry.
Doctor,
I'm going to mute.
okay, that sounds good. So thank you, I appreciate that. So basically, to recapitulate, welcome to today's CAC advisory meeting. The purpose of this meeting is to present the proposed LCDs for consideration and to take comments from CAC members. The public is welcome to attend in a listening only capacity. Disclosure, per the 2020 Cures Act, your attendance as a CAC member at this meeting implies that you consent to the public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the proposed or final LCDs discussed. If a CAC member does not consent to this, please disconnect. The meeting is also being recorded and transcribed. If you don't consent to the recording, please disconnect now. Now, some instructions. So when you're not speaking, please maintain your microphone in mute. To edit the transcription, before you make any comments, please state your name and conflicts of interest that you may have, or state that there are no conflicts of interest. Individuals wishing to comment may click on the raise hand icon, press star 3 if you are attending by phone, and then Mr. Staley will call on you. And please make sure that your microphone is on at your end and that your speakers are silenced to prevent an echo. CAC members should follow up any verbal comments in writing by sending an email to Medicare Policy Comments at wpsic.com. Today, we will be commenting on the following proposed LCDs. DL39788, that is cervical fusion, doing a sound check, I received a message that I'm not being heard very well. Can you hear me well?
Lord.
Hard to hear?
Yes.
Okay, then I'm going to, I was usually use my
Dr. Shaning, I'm
Yes.
sorry to interrupt. This is Dr. Nachowski with WPS. Maybe there is some back noise that I am hearing. I think others are also. If you could speak closer to your mic, or if anybody is not muted by either their computer or their cell phone, please mute yourself until it's your turn to speak and then unmute, because I see a few phones that look like they are unmuted, and that might be causing some extra noise in the background. Thank you.
Thank you. So, is this better now? Okay.
Yes, I heard that last one better. I've also been going through an auto muting open mics as I see them.
Okay, so let's continue then. The first LCD is the cervical fusion. The open comment period for the cervical fusion proposed LCD started on February 1st, 2024, and ends on March 16, 2024. The open comment period for the facet joint interventions LCD, DL38841, started on February 8, 2024, and ends on March 23rd, 2024. Your comments will not be addressed individually, but will be compiled and addressed in a response to comments document posted with the final LCDs. So let's go ahead to the proposed LCDs for comment. BL39788 cervical fusion is a new LCD which was developed as a multi-MAC collaboration to provide an evidence base for cervical fusion. Dr. Claudio Campos is the CND in charge, and the policy nurse analyst is Mr. McCarry. Dr. Campos, could you provide a brief summary of this LCD, please?
Happy to do so. Good afternoon, everyone. So the cervical fusion LCD is a multi-MAC collaborative LCD, as Dr. Shaming said, and there are three main covered indications for cervical fusion. Number one, for the decompression of symptomatic cervical nerve root impingement. Number two, for the decompression of symptomatic canal stenosis. And number three, for the decompression or stabilization of the cervical spine in the presence of traumatic injuries, spinal tumors, infection, or deformities. Only two limitations for this LCD: isolated axial cervical pain and asymptomatic myelopathy. Back to you, Dr. Shane.
Dr. Campos. So now after this brief summary, now let's open the draft for CAC members' comments. Any CAC member that want to comment, please proceed and comment on this proposed LCD.
All right, CAC members may unmute themselves if they would like to make a comment at this time, or press the raise hand icon. And I am detecting no raised hands at this moment.
Well, thank you, Rachel. Then let's proceed with the next proposal LCD. The next proposal LCD on the agenda is DL38841, facet joint interventions for pain management. And Dr. Juan Shemin, I'm the lead CMD, and the policy coordinator is Mr. McCarry for this proposed LCD. In summary, this proposed LCD is a revision. In summary, this proposed LCD is a revision and provides clarifying language and supporting evidence on the use of anesthesia in conjunction with facet injections and radiofrequency ablation. The number of levels covered under the policy is clarified and reviewed in the rationale for decision making. This revision is in response to a reconsideration request requesting an expansion of therapeutic joint injections as a first-line option. Language was added to the summary of evidence section with rationale for decision explained. No coverage changes were made because of this reconsideration request. The LCD is open for limited comment on the clarificatory language regarding the non-coverage of third-level injections, use of anesthesia in conjunction of passive joint injections and radiofrequency ablation, and for the added language to the section on the summary of evidence and the rationale for decision making. So with this said, let's open this LCD for comments from our CAC members. I believe Dr. Northrop wants to comment on the LCD. Please, Doctor, go ahead with your comments.
And Dr. Northrop, I see you are on a phone. I have sent a request on mute through your phone. I don't know if you'd have to press *3 on your end to get that.
All right. Can you hear me?
Yes.
Can you hear
Thank
me?
you. Yes, we can hear you.
Okay, great. Yes, so this is Ben Northrop, CAC representative from the state of Missouri. I'm a musculoskeletal radiologist, imaging and intervention at Mallinckrodt. Okay, so a few things to consider. First off, thank you for opening up these portions of the LCD. I think these are probably the three most important portions to talk about. The first topic to address is coverage of a third-level injection. So the literature and my personal experience in performing these procedures demonstrates that we don't often perform more than 2 levels, but when there is a third level and it is necessary and has a similar indication to the other 2, it certainly should still be done. The evidence previously and currently has risen to the level of a Category 1 CPT code for that particular indication, both at the cervical and thoracic level as well as the lumbosacral level. Those CPT codes are 64492 and 64495. That's the third and any additional level add-on codes for 64490 and 64491 in the cervical and thoracic levels, and 64493 and 64494 at the lumbosacral levels. So non-coverage of a third-level injection, when it is medically necessary, it incentivizes converting this to a staged procedure. This is going to introduce more inefficiencies in our workflow. It's going to limit beneficiary access and potentially create worse patient outcomes if they're unable to return for that third level when necessary. And of note in the LCD, certainly there's some excellent references there, articles that many of us are familiar with and give a good review, as well as excellent high-quality randomized controlled studies discussing these procedures. However, in none of those articles does it suggest that when indicated that injecting a third level when you've already done the first 2 is ineffective. And to my knowledge, no evidence exists in the radiology or pain management literature. So that's the first point. Second point is the use of sedation or anesthesia in conjunction with facet joint injections. This is mentioned in points 2 and 3 of the limitations section. So sedation is really not very commonly used for these, especially if it's simply an intra-articular facet joint injection, whether it be diagnostic or therapeutic, or medial branch blocks, radiofrequency ablations, etc. However, facet cyst rupture and aspiration can be quite painful, and some patients simply will not do it without moderate sedation. In my practice, we probably do this about 20% of the time or so. If a patient really has had pain with one in the past and does not wish to repeat that, or some that simply are just simply afraid that this would cause too much pain and don't want to do the procedure otherwise. So the problem with that is the alternative, if we do not do this procedure, is often surgical decompression, which from a morbidity and cost standpoint is going to be quite a bit worse than simply accessing the facet to rupture the cyst or directly accessing the cyst when that is an option. There's a number of articles that I saw that you said, all excellent articles that mention that anesthesia and sedation is not necessary. And I agree with the simple facet joint injections, the medial branch blocks, et cetera. However, none of those articles say that it is unnecessary or inappropriate in the setting of facet cyst rupture or aspiration. So I think at a minimum, we should clarify the LCD and make sure that portion is clear, that it is indeed indicated in some cases for facet cyst rupture and aspiration as opposed to the other situations. And then the third portion of it that was open to comment, it kind of relates to the second, at least the point about the facet cyst rupture and aspiration. So it discusses the expansion of the therapeutic joint injection as a first-line option. So in many cases, the diagnostic facet procedure is unnecessary. I don't know as if we need to limit the therapeutic injection and simply say no without a diagnostic injection at first, especially in the case of the facet cyst rupture and aspiration procedure. In my practice, we never do an initial diagnostic injection. It's unnecessary if we see the cyst well on MRI, if we know that this thing can easily be accessed. And really, it doesn't matter very much if the patient responds to a diagnostic injection, because the goal is not to inject the facet and see if they respond. The goal is to simply rupture the cyst the first time and avoid a two-stage procedure. And let's see, there was one more point on that. Let me find it. 1 second here. Oh, yes, and also on that topic with the facet cyst rupture and aspiration, this relates to the third portion of this that was open to comment. You do mention that cyst aspiration and rupture may be repeated once and only if there is 50% or more consistent improvement in pain for at least 3 months. Agree completely with this, and the literature supports it. However, I think we do need to clarify that these limitations apply only to each individual cyst. For example, if someone has a cyst arising from the left L2, L3 facet joint, and then also has a cyst arising from, for example, the right L4, L5 facet joint, these are two completely separate cysts, and it should be clarified that these can be treated separately, and each cyst deserves the first and the possible repeated second procedure. So, yeah, I think that's about it. So thank you for the opportunity to comment on these 3 open portions of the LCD, and I'm happy to take any questions.
Do any of my colleagues have any questions for Dr. Northrop?
Thank you so much, Dr. Northrop, for your very informative and detailed with literature for in regards to this LCD. I'm just going to ask if you could please put this in writing and send any of those extra articles that we may not have so that we can review them. It'd be greatly appreciated.
I second Dr. Nachowski. I really appreciate your very detailed comments on our LCD. It would be extremely beneficial if you could send them to our policy comments box and with any literature that you think is pertinent. But I really appreciate your commitment to the Medicare program and trying to do what is best for our beneficiaries and to improve our proposals in this. So thank you for your very detailed comments on the proposals. Any other comments from?
Yeah, thank you. I will submit in writing. Thank you for the opportunity.
Okay. Hearing no other comments.
Actually, I raised my hand. I apologize.
Sorry, I didn't see that. I apologize. Go ahead, Dr. Joe.
My name's Kit Young. I'm the anesthesia CAC for Missouri and also the chair of the CAC for Missouri. I appreciate Dr. Northrop's comments and excellent review. I would just add one small point of clarification that when it becomes necessary to do moderate sedation, it's because of the positioning of the procedure, it may well be necessary to include general anesthesia in that scenario because the patient may not be able to be sedated safely in that position. It's a logistical thing that will depend on who's providing the moderate sedation or anesthesia. Thank you.
Thank you for your comments, Dr. John. Any other comments from our CAC members? Please.
My name is Matthew Safari, and I'm from Michigan State University. I'm interventional pain for PM&R. Sorry, my kids crying in the background. But I just would like to thank Dr. Northrop for that. I think he did a wonderful job, and I'm in total agreement with his comments. And I just like to thank him for his points today.
Thank you. Appreciate your feedback. Any additional comments? You may use the hand icon or press star 3 if you're on a phone. So
Kimberly Hayes Henson, I believe, has a comment.
Yes, once again, I appreciate Dr. Northrop's comments. I'm from Nebraska. I'm an interventional pain physician as well. And I agree with the evidence that's been presented. I also wanted to mention that I have one patient right now who has facet joint disease that has responded well to medial branch block and RFA. Then she has one normal level below that, and then below that has another abnormal level. And so I'm unable to address that second abnormal level because of the fact that I've already used up her benefits for the year.
thank you for your comments. And remember, you can send these comments. It's really useful if you send this to the policy comments at wpsicu.com box email. That way we can address that during the comment period and respond to these comments on the comment response document when we finalize our LCD. So I greatly appreciate all the CAC members' comments, and please send those important comments to our policy comments box.
Thank you. We do have another comment from Michael Bohl.
Yes, thank you. I am the beneficiary representative from Iowa. No conflicts. I'd ask you to give a lot of weight to any concern about having patients come back because they can't be fully treated when they're there and under the care of the physician and under whatever anesthesia they're being given. It puts the patient in a bad spot to not be able to have their treatment completed, to have to go home, and then either come back, another day, another week, another month, another year, whatever. So anyway, please give those comments a lot of weight. And anyway, that's what I have to say. Thank you very much.
And thank you, Dr. Bohl, for your comments.
All right, I see no more raised hands at this time.
So, if last call for comments, if there are no additional comments, then this concludes the presentation and discussion of the proposed LCDs. I would like to thank the public for attending, and you may disconnect now. After a moment, we will continue the CAC members only portion of the meeting where we will address contractor updates, projects, and provider engagement. Please, thank you for finally, again, thank you for your participation. And now I turning the meeting to the hands of Dr. Keith Young, when which confirms that there are no other non-CAC members on the line.